teach you how to be doctors. And this is your second... Is it better from here? Is that better? So we're going to be talking about your second area in the history taking. This is history taking 1. I think Dr. Ayman took history taking... Sorry, this is history taking 2. Dr. Ayman did history taking 1 with you the other day. We're just going to revise and go over that slightly. And then you're going to be practicing these skills that we're teaching you. So we're giving you some theory for an hour, but then this week and next week you'll be putting into the theory into practice. So listen well. And we'll be then getting you to role play. So one of you will be a patient, one of you will be the doctor or a student doctor, and then there will be some feedback as well. Does that sound okay? Kushi Tamam? Yeah? Mafi Masari? So this lecture we're going to be looking at just a review of history taking, consultation skills, the first lecture, and we're going to look at particularly why it's important to be patient-centered. So really hone in on what does it mean to be patient-centered, putting the patient at the heart of the consultation. Then we're going to look at a little bit more of the structure of the consultation. So I think Dr. Ayman should have looked at presenting complaints. Today we're going to go in a little bit more detail of the history of the presenting complaint. How do you go into the history a little bit more detail? And then we're going to look at the past medical and surgical history, which will be one slide, because that's pretty easy. But as well as the structure of the consultation, like building a building, we're also thinking about what are the skills. So there are things that you want to use in your communication with patients as skills, something you need to learn. And these are some of the skills that we're going to look at. Open to closed questioning, clarification, what does that mean? Picking up cues, what's a cue? Summarization and signposting. So these are some of the consultation skills you're going to use in the consultation. So it's like we're on a journey, and you're walking with a patient on this journey. And you want to go along with them, but you also want to steer the journey in a direction you want to go as well. Okay? So, did you talk about this with Dr. Ayman last time? The setting of the consultation, looking at the room, looking briefly at the patient profile, what that means, the presenting complaint, and some of these consultation skills, the introduction, how you introduce yourself, and open questions and closed questions and clarification. Did you look at that last time?
Yes.
Okay. So, just thinking about that first question, what about the setting of the room? How does that look? And you can see a very... This has got infrared on it. Yeah. Yes, it does. So on the left, you've got a very traditional doctor's office. Yeah? The big desk, the big leather chair, all the certificates around the room, look how important I am, look how well I've done in medical school. And then the patient's chair in front of the desk is a little bit lower than the doctor's chair, because the doctor's more important, right? So that's often a typical look in a British, general practice surgery. Maybe it's the same in the States, I don't know. No. But here we have a very different style of communication in this room. What differences do you notice? Over to you. Yeah. There's no desk. There's no barrier between the patient and the doctor. Brilliant. Yeah.
The patient and the doctor beside each other.
Brilliant. So it's a partnership going on. They're working together. Yeah.
It's less formal.
It's less formal. It's more relaxed, right? You may want a cup of coffee in the middle of all that. Yeah.
It's more of a free conversation.
Yeah, it's more of a conversation than you're coming to get what I'm telling you. Yeah, it's definitely more of a partnership conversation style. Anything else? Yeah.
To be closer to the patient.
Brilliant. So, as well as there's no barrier, it's actually closer to the patient. So if he needs to show empathy, is anything difficult, they can do that as well. Yeah. Yes, the lady over here. There's a screen. So they're both looking at the screen. And that's really helpful for looking at results or x-rays, or here's an x-ray for example. Whereas you're sharing the information together. It's not the doctor's behind the screen and he's hiding something from you. It's all open. Yeah? Any other thoughts? Yeah?
It's the main idea about patient-centered medicine.
Exactly, my friend. I can pay you later. So exactly, that's what we're trying to get at. What is the patient? How do we put the patient at the centre? And even how we set up the room, tells the patient if they're at the centre or not. An open question. What's an open question? Yeah, the guy in the middle.
Something you start a conversation with?
Yeah, something you start a conversation with, hopefully. So it means that it allows the patient to just tell their story. It's not a yes or no answer, it's open, so you can say whatever you like in this moment. Okay? Clarification, what was clarification? Anyone remember? Yeah?
Is to know what the patient means.
Brilliant. So sometimes the patient says something and we think we know what they mean, but it's not actually what the patient means. Or they use a medical term and we think we know what it means and we have an explanation of what dizziness is, but the patient means something else. So you need to clarify what they mean by what they say. Yeah? Brilliant. And also checking. You're also checking about what they're saying. Have I got this right? Can I just clarify? You said this is also what you meant. Did I hear that right? So you're also checking. Yeah. Okay, yeah?
Clarifying for the patient the question that you want to...
Brilliant. So sometimes your question isn't always the best or it's not understood. So sometimes it's also clarification of yourself about your question. So you may need to frame the question, like the picture has a frame. Sometimes when you're going to ask a question, you want to frame it to help the patient understand the question. Great, yeah. Okay. You're very interactive, I like this. Active listening. What is active listening? Yes.
To listen to your patient without interrupting.
Brilliant. So the first thing is not to interrupt the patient. Yeah, brilliant. That's part of active listening. Yeah.
Not do anything but listen.
Do nothing but what?
Listening.
Just listening. Yeah. So don't look at your screen or look out the window because it looks more interesting than the patient. So you've got your whole focus on the patient, absolutely. Or we could be writing something maybe in that scenario. So you're giving full focus to the patient. Brilliant. Yeah.
What do you mean by patient-centeredness?
We'll come to that in a second. I've got another slide. Yeah. You're clarifying me.
Using nonverbal cues to encourage the patient.
Right. So as well as the way that you are positioning your body, looking at the face-to-face, you want eye contact, you want to be the same level. You're also showing that you're actively listening by the nods of the head, yeah, carry on. You're showing that you're actively listening by the way that you use your body language, the gestures, but we'll also look at some of the consultation skills later as to how you show that too. Yeah? Any other thoughts? Yeah?
Those patients to think before answering.
Yes. Sometimes. Okay. So somebody asked, what is patient-centeredness? Now, why we think this course is great is because we want to move you away from traditional models of medicine. Now, in the UK, it's all about this patient-centeredness. 20, 30 years ago, it was all about the medical model. Okay? So in the medical model, the patient's quite passive. You're the doctor, you're in charge. Okay? And you'll tell the patient what's right. In the patient's role, you're trying to encourage active listening because you want the patient to take control. The patient is the recipient of treatment. So you tell the patient, here's my instructions, this is the prescription, this is what you need to do. Yeah? Whereas in the patient-centered model, the patient gets involved in that decision. They're a partner in that. What about another treatment doctor? Is there any other options? What are the pros and cons of that treatment? I'm not sure I want to do that. It doesn't suit my life right now. Maybe I could do this in a few months' time, but not right now. So the patient's involved in that decision making. Again, when you look at the medical model, in a particularly the conversation, the doctor dominates the conversation. He doesn't offer those options we just talked about. He says, no, this is what you're going to do. But in the patient-centered model, the patient collaborates, works with the doctor, and options are discussed, and the pros and cons, what's the advantages and disadvantages of that decision or that treatment. Again, with a medical model, it's all about the disease. It's all about what's wrong. And it's not really, if the patient gives you some ideas about how upset they are, or the stress in their lives, or other issues, we ignore that in the medical model. Whereas in the patient-centered model, we look holistically. You know what holistically means? Holistic means that you look at the patient as a whole. So it's not just the disease that they've got, it's also looking at the psychology of the patient, how they're feeling about this. It's also looking about their lifestyle, what their job is, the effect of this on their social setting. Does it affect the family if they can't work? If they've got back pain, suddenly they can't work. The whole family suffers because they're not getting money into the family. So holistically, looking at the whole thing, how it affects the patient. So it's about the quality of life, yeah. Again, medical model, the doctor does most of the talking. Here we're trying to encourage more listening and less talking. And then basically the patient may decide to leave the room and they may follow your instructions in the medical model, but often not. They may go see another doctor, they don't like you. But really we're trying to get the patient to understand the plan, understand why you've chosen this, the decision together, and they're more likely to take your medicines, for example, more likely to change their lifestyle if you've involved them in the decision. Yeah, it makes sense. Does that answer your question on patient-centeredness? Okay. So, opening questions. Has anyone thought about this before? Has anyone taken a history from a patient yet? Nobody. So no one's heard. Dr. Joel has. Okay, I'll ask Dr. Joel. What's your opening question that you'd like to ask patients?
Well, often I will ask, oh, how are you doing today? Which is a dangerous question because, well, I'm in a doctor's office, so not very well, right? But more commonly what I'll ask is, what brings you to see me today? And they could tell a joke like, oh, well, my car brought me to see you today, or the bus, but they may actually just come and tell you. But it starts the consultation off open and also lighthearted and lets them get started sharing what brought them in today.
Great. Okay, that's one option. Yeah.
Or maybe we say the weather is hot, isn't it?
Okay, so you can have some chit-chat, as we call it. So the weather is hot. Yeah, is there a danger in that question, or a danger in starting like that? Have you ever been in a pressured clinic where you've got to see 30 or 40 patients? You've only got maybe 5 to 10 minutes with each patient. Yeah, there's a danger that if you start chit-chat with everybody, you're going to not be going home till midnight. Yeah, okay? So yeah, time is precious, so thinking about the opening question is important. So yeah, here's some examples. Yeah, Dr. Joel sort of talked about how are you doing? Now there's a danger in that question, as Dr. Joel said. What is the danger of that question, how are you doing? Yeah?
It's good you won't come to me.
Yeah, maybe. Okay. Yeah.
He might not tell you this whole story.
Right, so he might be talking to you about how he's doing, how he's feeling, and all these other things, when actually you want to get down to what the main problem is. So it detracts, and you get into this whole, oh, I'm feeling like this happened to the kids, this happened to my wife, and so the whole first 5 minutes is just him talking about how he's feeling, how he's doing. Yeah. How can I help you today? What's the disadvantage of that question, maybe? Yeah?
Everybody uses it.
Everybody uses it. Yeah, it's common. That's not usually a problem, but yeah. Yeah?
The patient will tell you about his disease and his problems.
That's what we want, though, isn't it? Yeah, we do want them to tell us about their disease and their problems. Yeah. Hey, yeah, go on.
Maybe the patient will tell you about his life more than his disease.
Okay. Yeah, actually, I think the problem with this question maybe is that it assumes you can actually help. As doctors, that's what we want to do, that's that part of our role, but we can't help everybody. In some such situations, you may not be able to help. So it makes an assumption, an expectation that you could actually help them. And that's what we're trying to do, but we can't do it for everybody, or the situation is difficult. I actually say, oops, over to you. So I just say, over to you. I'm actually saying, have the floor. It's your control now. Over to you. What do you want to talk about? So I actually just say, over to you, and do the gesture as well, and wait for them. Yeah? So I'm not making any assumptions. Or, I heard that one doctor said he went through a whole clinic without saying anything. So just let the patients talk, and let them just leave the room. I don't know how he made decisions, but it shows that actually saying nothing, just giving a pause, using silence can work as well. So good beginnings make for good consultations. There are many different ways to start. Choose a question you like. It's comfortable for you. They talk about the golden hour when somebody arrives at the ER department. You have a good hour when someone is very ill, and what you do in that first hour makes an effect on the life of the patient in an emergency. Yeah? It's the same with the consultation. The first 2 or 3 minutes, how that goes, affects the whole of the consultation. So good beginnings make for good consultations. here's a little bit of theory, a little bit of evidence for you. There's a study into how frequently, or how long it is rather, until doctors interrupt the opening statement of a patient. So if you anyone watched House, the American doctor show, they say 10 seconds. Actually, it's about 18 seconds. That's how long, on average, doctors take to interrupt patients. The longer you actually wait, then the more complaints you get from the patient. Because patients don't tell things in the right order. You know, they may say the first thing and you think that's the only thing they've come with. But then maybe the third thing they mention is coughing up blood. Now that gets you interested. And that actually is really what you want to talk about, because that's really important to talk about. So letting the patient list all the problems, give them as much time at the beginning, gets you all the different complaints, and also helps you prioritise, work out which is the most important to talk about. Yeah? And often when it goes wrong at the beginning, this is Bernard Long at the bottom, interviews were likely to become more dysfunctional, particularly if it went wrong at the beginning. So that's the skills for initiating the consultation, setting the room, making sure the patient's comfortable, establishing rapport, greeting the patient, obtaining the name, making sure you're talking to the right patient. I have been talking to the wrong patient a few times, that's very embarrassing. Introduce yourself in the appropriate way, demonstrate an interest and respect to the patient, and then we're going to try and work out why they've come, make sure we screen for all the different things that they've come with, and then work out how we're going to negotiate what we're going to talk about. So let's talk about what I'm going to talk about today. That was just a brief summary. One thing actually maybe Dr. Am didn't cover so in depth was just about the patient profile. Do you know what the patient profile means? Has anyone been reading the clouds?
Yes.
Yes.
Name, age,
Name, age, brilliant.
gender,
Gender,
date,
address, where they live, yeah. What kind of housing?
date of birth,
Date of birth. Occupation, very important. Yes. Blood group, could possibly fit that in underneath everything, yeah, maybe. Yeah.
Indications.
Medications, no, it's just literally who the patient is. So name, date of birth, where they live, what the occupation is, are they married, have they got children, you know, that type of thing.
of his medication.
Medication comes in part of the big history. Yeah, further down.
location,
Oh, location, yeah, where they live, location, yeah. Yeah, great, I don't need to teach on this then. Yes? Say that again. Yes,
Yeah.
are they married or not? Yes, I said that, yeah. Great. Was there anything else I needed to cover? John, was it about presenting a complaint, I think?
That's
Yeah, okay. So the history of presenting a complaint. They say that 80% of a diagnosis can be made from a very good, careful history. So it's not about how well you use your hands and listen well, it really is about communication. They say that doctors who from the hospital receive referral letters, you know, if it's a good referral letter, then basically they can make a diagnosis just from the letter. Probably about 80% of the time it's accurate. So how well you listen as a doctor, you know, and how well you get the information that you need can make a diagnosis for you right there and then. So that's why open questions allow for a good explanation of the patient what's wrong. If we cut that off too quickly, then we lose that valuable information at the beginning. It says multiple closed questions don't usually help you get a lot more information. It's all in that beginning statement. Yeah. So a good opening question, tell me more about, or you know, what's over to you, what's the matter today? Clarify what the patient means. So what do you mean by dizziness? You know, well, what is the pain like? What's the pain? How would you describe the pain? You want to get a little more detail when you're doing the history of the presenting complaint. So I'm not expecting to know everything about medicine today, but just have a little bit more detail about what the history is. So tell me a little bit more about that. What's that feel like for you? So you want to go dig deeper. You also, in the history of the presenting complaint, you want to know when it started. Yeah, and what's the sequence of events. Often when people talk, they go around in circles, and you're kind of trying to work out when it actually did start. What were the sequences of events? And that's part of clarification. Let me just clarify, when did it actually start? You know, you said this, where does that fit in the story? You're trying to piece the whole story together chronologically. And then you will use closed questions. You will use some yes and no answers because you're worried you don't want to miss anything serious. You know, the red flag symptoms, the alarm symptoms. So somebody comes in with a headache or dizziness. There are a few symptoms you want to just check with the patient that you're not missing something serious. Yeah? In the UK, we talk about the red flag symptoms. So for a referral letter, if we're thinking we need to send this urgently or non-urgently, we're thinking about, do they have any red flag symptoms? And a red flag symptom increases the chance that it's something serious. Yeah? So we want to be safe. We want to make sure we don't miss anything. And that's why we have those other closed questions as well. So communication is an art. You know, I've not arrived yet. My picture is still being made. We learn communication skills all through our careers. You know, we don't just learn it in 2-3 years at Hashmite University, I'm afraid. It carries on after that. Even when you get married, even more so. So, what are red flag symptoms? Well, as I just mentioned, symptoms that prompt a prompt referral or something worrying. So, if you take dizziness, for example. Someone complains of dizziness. If they describe one-sided, unilateral, ringing of the ears, tinnitus, or hearing loss, that's worrying. Because that's localizing, that's moving to one place. It's not all over. Okay? Or unilateral, running gooey stuff from the ear, otorrhea, that's again something worrying. Something in the brain's causing that. So you want to, maybe that's another red flag. Or any tingling or numbness, or weakness in the arm or leg. Again, that's a neurological symptom, that's a red flag symptom for dizziness. Or significant vertigo lasting for more than a month. Often vertigo lasts a couple of weeks, gets better, nothing to worry about, alhamdulillah. But if it's going on for a month or longer, then that's a time. So how long something's been happening for can also determine, you know, how concerned you are. Open to closed questions. Open to closed questions. So it's about a cone. You start open. You want to get as much information at the beginning, but then you want to drill down to a point, to a cone. You're trying to make a diagnosis. Now, at the beginning, it's a working diagnosis. You don't know everything yet. You haven't got your tests. You haven't done your examination. But you're trying to close down to where you want to hit the target. Now, as medical students, you won't know in your first year everything about everything at the moment. Even when you've been practicing for 30, 40 years, you won't know everything about everything. But the more information you know and understand, the more you can ask better questions. Yeah? Asking the right question, the target question. Take, for example, dizziness. Now, as you go through the next few years, you'll realise that there's two main types of dizziness. Vertigo with the room spinning around, and lightheadedness with the kind of feeling like you're going to collapse to the floor. So actually, a good way of starting when they talk about dizziness is clarifying what do you mean by dizziness. And then you may actually go, is it like the dizziness where the room spins around? Or is it like the dizziness where you feel faint, where you feel lightheaded? Yeah, because that's really helpful for you to then work out where you're going to go down your diagnostic tree. Yeah? So you're trying to move from big to honing down to one of these several different diagnoses. Take, for example, vertigo. Okay, now my next question, what's a good question to ask next? How long has it been going on for? Is this an acute problem, just a few days? Or has it been going on several times in the last few years? Because that determines what other diagnoses I'm thinking about. So acute, lasting maybe a few days to a few weeks. Repeatedly, you think about a common thing called benign positional vertigo. Whereas if it's very acute and they talk about unilateral deafness, one-sided deafness and ringing of the ears, you maybe think about Meniere's disease. And you want to get that investigated more quickly. Or even Ramsay-Hunt syndrome, more worryingly. So you use your open questions to start with, then you ask another good differentiating question next, and then you use more specific closed questions, yes and no answers, to get to your diagnosis. فهمت علي؟ كل شيء سمعان؟ So when you start as a medical student, this is how you ask questions. Okay? You're like a machine gunner, yeah? A machine gunner. Because you're not quite sure what question will hit the mark, yeah? So you hit the target all over, and maybe you do hit the middle, yeah? But you don't, at the moment, know enough, yeah? And it's okay, that's fine. And it's good to know good questions to ask, having a process. When you get to be maybe a family doctor or an internist, then you'll ask more specific questions, you'll ask fewer questions, yeah? And you're going to be like a sniper, yeah? Who just hits the target more easily and more quickly, yeah? Take, for example, pain. That's a good one to talk about with a history presented complaint. So with pain, you've got some specific questions you want to ask. You want to ask, where is it exactly? You know, when did it start? What's it like? Is it sharp and stabbing? Or is it like an ache? Or is it like a heaviness on your chest? Does it radiate? Does it go anywhere else? Does it go to your shoulder or to your jaw? Or your shoulder tip? You know, does it move? Or is it just that one place? How severe is it? You know, on a scale of 1 to 10, what would you give it out of 10? So just get an idea from the patient's perspective, how severe is it for you? And then, is it there all the time? Does it come and go? What's the pattern? What's going on with the pain? Does anything make it better? When you're walking up the hill and you've got this heavy chest pain, when you stop, does it disappear? Or actually, yeah, when I start exercising on the treadmill at the gym, that's when the pain happens. Yeah, you want to know what brings it on and what takes it away. And finally, is any other symptoms around pain? Do you get any sweating? Do you feel lightheaded with the pain? What's happening with the pain? Okay. So that's, for example, this is more closed questions with pain. So that's a good framework for pain, if you think about pain. Quickly, just the past medical and surgical history. This is again the structures. You've done presenting complaint, you've done the history of the presenting complaint, and now you think about structural consultation in past medical history and surgical history. So you're trying to work out, has the patient got any medical problems? And here's a few open questions you could use. Have you had to take do you take any medications for anything? Working out what medications someone takes, I can really tell you what diseases they have. Yeah? But at the beginning, you probably won't know that yet. Have you had to take time off work with illness? Have you ever had any operations? Have you been to the hospital clinic for anything? So you're just asking about admissions to hospital, operations, any medical problems that you have. More closed questions related to the history of presenting complaint would be, have you had this problem before? Have you come about it today, have you had it before though? Or have you been in hospital with this before? What did they say? What did they think it was? So Q. What's a Q? What's a Q in the film industry?
Evidence.
Evidence. Not quite. What's a Q? He came in on his Q. Do you know the kind of the tape thing they do? Yeah? So that's his cue, or an actor has to come in on their cue. So a patient stops talking, and then it's a cue for the other person to start talking. So a cue is an opportunity, or you see a signal, or something for you to start talking or to see something. Yeah? So it's something that's said or done by the patient. That's a signal. It's a sign to us about what the patient's thinking or feeling. Okay? So this cues can be further divided into verbal cues, what they say, and non-verbal cues, the way that they use their body, the way they posture, the way that they show their emotions in their face, for example. Even the way that they use their eyes. There's lots of research looking at to what position people's eyes move to determine what they're thinking about. It's really interesting, if you want to go into a lot of depth about it. Because communication is an art. We want you to become artists. Non-verbal. So we talked about body language, speech and facial expression. So how patients present themselves also tells you a little bit about the disease process. Even just watching a patient walk into your room tells you a lot about their gait, you know, what's going on there, how stressed they look, when they sit down, you know, the expression in their face, what's going on there, do they look worried, look a bit stressed, are they wringing their hands a lot? You know, these could be a psychiatric condition, it could be part of thyroid disease, it could be just how the patient's feeling. But you get this whole picture of the patient. And you may notice that they seem very agitated with something that you might have said. So if you recognise the cue as a signal to you that they're not happy, pick it up, show, you don't seem happy about what I just said, or can I just ask you seem a bit stressed today, or you know, you just show that you're watching the patient. Yeah? So that's picking up cues. How do I pick up a cue? You mentioned that you're upset at home. Upset? Let them just talk. What do they mean by upset? What's going on? You said you're worried that the pain might be something serious. You know, what are you worried about? What is it you're worried about? Why are you worried about this headache? It's because my aunt had a headache before she had a brain tumour. That's what I'm worried about, that this is a brain tumour. But you'll never have understood that until you ask the question. And then that will make you actually determine what questions you ask the patient. Because if they're worried about a brain tumour, you're going to ask the red flag symptoms, you're going to ask about the worrying symptoms of a brain tumour, and then examine them in a certain way to rule that out, or rule it in. You know, you're not sure yet. So it actually determines what you ask as well. Non-verbal cues, when the sense that you're not quite happy with the explanations I've been giving you, or you've been given in the past. That's why you're seeing me, the fourth doctor in the week. What is it that you think is going on? Is that right? But to pick up cues, you need to keep the eye contact. You need to be watching the patient all the time. So if a doctor starts looking at a computer or writing, you'll notice the patient often tailors off talking. They want you to get your attention back. So you need to be always keeping good eye contact. It's always good to write notes after the consultation rather than now. And if you need to check notes, just check with the patient. Do you mind if I just check notes for a short while? Signposting, another skill. Okay. What is it? Well, signposts direct you in a certain direction. Yeah, that's why we have them. I lived in Libya for a while, and they were worried about the Americans invading Libya. So Gaddafi, he put in all these signposts to point people the wrong direction, because he thought if there's an invasion they'll all get lost. I thought it was quite funny. So
the Americans invaded
why do we use a signposting tool? It's used as a way to summarise. So we're saying, right, this is where we are in the consultation. Let me just say, this is what we've talked about so far. So you're saying, this is where we are in the consultation. This is how far we've got. So it's a sign to the patient, this is where we are in the consultation. And also it's just a way of checking that you've not missed anything, that you've got everything right up to now. But then it helps you move on to the next stage of the consultation. So we've done a present complaint, we've done a history presenting complaint. Let me just say, we've clarified the story. Can I just check with you about, have you got any of the medical problems? So you're saying, this is what we've done, and this is where we're going. So this is where the next direction of the consultation is going. And you may also use it from, like, for example, open to closed questions. So you've told me a little bit about the pain. Do you mind if I ask you a few more questions about the pain? And then you get your closed questions. So does it radiate? Does anything make it better or worse? Then you ask your closed questions. So it's a way of, moving on to another area that we want to talk about. So there's two reasons why you signpost. But it's an art. The final thing that we're pleased to know is about summarisation. So this is where a patient gives you an opening statement, and then you find out a little bit more and you get a bit more detail, but then you summarise what you found back to the patient. Okay? So that shows a few things. Well, what does it show? If you summarise it back to the patient, how does that help you as a doctor? Yeah?
To know if you catch the right details and diagnose the patient well.
Fantastic. So have you got it right? Have you heard them correctly? Clarifying the story. Brilliant. Yeah?
You can ask if there is anything else the patient would like to add.
Yes, so while we're summarising, there might be more information you just wanted to add in. Brilliant.
To maintain the patient is still on track?
Yes. Yeah. Often what patients do is go round and round in circles, telling you the same thing. That's a little bit irritating when you want to get through 30 patients. So to show the patient that you've listened and to stop them circulating, you need to show that you've listened and say, this is what you've said, and then they realise you have heard them. Yeah? So patients often do that, they repeat the same things, yeah?
Clear up patient mind.
Say that again.
Clear up patient's mind.
Clear up patients.
Mind.
Clear up the mind. What do you mean? Sorry. I'm not sure actually. Talk to me afterwards if you have a question. Yeah? Sorry, say that. Yeah, to remember the important things. It helps you and your thinking to structure what's been said. So it helps you get a structure of what's been said, absolutely. Also it shows active listening. It shows that we're listening to the patient. Now, when you summarise, be careful how you summarise. I found this too in my years of being a doctor. I used to just give my interpretation of what they said. So I maybe used some medical terms, I might have said things slightly different from what they said, and patients correct you. Even though it's the same thing, maybe using slightly different terms. Parrot fashion what they say back to you. That's why I've got the picture of the parrot. Use the exact word as the patient says. That helps. And then you don't go in this repeating cycles. You're not trying to give any interpretation at the moment. You're not trying to give any advice or opinion or reinterpretation is what I was just talking about. You're just trying to say, this is what you've said, now we can move on. Yeah? But it also gives you time. So when you're summarising, you're thinking, what is the next question I'm going to ask? It gives you time to think as well. And then maybe there's a few more things you want to add. So it gives you some time in the consultation. So that's it. Okay. Any questions? Anything you want to ask? Yes?
I didn't understand what does red flag mean.
Red flag. Okay. So, do you know like a red flag in the arena of a bull and a matador? The red flag is in front of the bull, and basically the bull goes for the red flag. It's danger. Yeah? So that's like a red flag, or a red flag is put down at a railway, stop the train. The red flag is put down to stop the train. So a red flag is a symptom where it's an increased likelihood of a cancer, for example, or a serious diagnosis. Take, for example, somebody coughing. Okay? And if they say, I'm coughing up blood, most of the time it's not cancer. But increasingly likely of all the other symptoms, if they coughed up nothing, versus coughing up blood, it is more likely to be cancer if somebody coughs up blood. Does that make sense? You can have lots of reasons for coughing up blood, but one symptom that increases your chance of having lung cancer is coughing up blood. Any other questions? Yes, the guy in the middle.
What the benefit from pick up eye contact on a patient? We already talking about what he's suffering from.
Sorry, can you repeat the question nice and loud? I can't quite hear.
What the benefit of picking up eye contact with the patient? We already talking about what he's suffering from.
So what's the benefit of keeping eye contact, maintaining eye contact? It helps rapport. You know what rapport is? Relationship. When you first meet someone the first time, they say you should keep eye contact with that person for at least 3 to 5 seconds if you want to build a good relationship with that person. So it helps rapport, relationship building with a patient. It also helps you see how they are looking. What's their body posture, what's the gestures in their face. You're looking for cues. Yeah? What's going on with the patient. Also helps you show that you're listening. Yeah? Even if you're switched off up here, at least it shows that you're still listening if you've got eye contact. It's part of communication. It's part of who we are as humans. I think that's it, isn't it? Okay, so.